don't know when that moment is.
No, you don't.
It's a pretty picture behind you, though. And I think, are we live? Are we live? Yes, we are. Hey, everyone, and welcome to Chef AJ and Friends. I'm your host, Chef AJ, and it's not the third Friday of the month. I think it's the fourth, but we got the day right, which means it's time for The Doctor is In Q&A with Ron Weiss, where he answers your questions. But I thought just for fun, since we've been talking about this lately on the show, chest pain, maybe Dr. Weiss could unwind a little bit about chest pain and like how we know when we should go to the emergency room because maybe it really is a heart attack, or in my case, costochondritis, because I got to tell you, I'm told it feels pretty much the same. Please welcome Dr. Ron Weiss to the show. How are things in beautiful New Jersey?
Oh, it's been extremely dry summer, one of the driest on records in recent memory. So that's not necessarily good for a farm.
Yeah,
It can stunt and change the quality of the vegetables and the fruits. However, it's better than floods. So if faced with either flooding or drought, as long as a farmer has irrigation, we choose drought. However, we'd like there to be normal rain. And
right.
you know what? I don't know if I know that California, where you are, it's just dry mostly. I haven't heard anything about the fires, by the way, this summer, but here, our weather patterns for the summers are changing. I would say for the last 4 years, they've all been dry like this.
Wow. Well, you have
But
a wonderful new addition to New Jersey because our very own plant-based Dr. Matt Letterman just moved to Princeton just a week ago.
I know everyone's coming the other way now, from California to New Jersey. Go figure that one.
Yeah, that's something.
I can't wait to meet him in person.
Yeah. Well, you guys are going to be fast friends, I'm sure. So, yeah, I mean, chest pain. How do you know when to go? Because what if you don't
Well,
go?
tell us a little bit about what happened to you.
Yeah, so I started having right after my last Keytruda treatment, I started having pressure pain just right around here. It wasn't terrible, but it wasn't nothing. And I thought it was probably because I have anxiety, but then I thought, but why would anxiety just be so localized? Anyway, it just got worse and worse. And then finally, one day last week, it was just crushing chest pain, pain when breathing, shortness of breath when laying down. And I went and, they do every test that they do. And um, everything was normal. And so they said, do you have costo? Because when they were pushing here, no, this doesn't hurt. They gently pushed my chest and I screamed. They said Costco sounds like Costco chondritis, like what you get from spending
Yeah,
too much money at Costco. So Costco chondritis, and I've been looking it up a lot on the internet, and boy, a lot of people have it apparently, but I've never heard of it before.
yeah. So the term costo means is the root for rib, and chondra means cartilage. It's it's because the rib cage is bones uh, joined by a cartilaginous joint or cartilage joints where the ribs, the strips of bone are joined to the sternum. And you can, if you look at a skeleton, you'll see like these rubbery tannish areas. Those are the cartilage areas. And then, of course, in between those strips of bone are ribs. Like in our past, I know that probably in my past and your past, we've eaten Chinese spare ribs at some point. You were eating the muscles between the ribs. So that's what. So costochondritis means inflammation of the rib joints. So that's the term they gave you. We'll back that up a little bit. That is a cause of chest pain. Um, you know, um, chest pain is something to talk about because it's not uncommon. And I think eventually it occurs to most of us sometime in our lives. And although most chest pains are benign, um, some of them can kill you. So that's why I think many people get freaked out when they get chest discomfort and they decide to go to the emergency room or urgent care or their doctor. Um, so I was an ER attending for about 7 years, and I saw a lot of chest pain. And I developed a system at that time to sort of wade through the different kinds of chest pains and decide if they were going to kill someone or they were just going to be going home and going to sleep in their own bed. So here's the way I settled it in my mind. There are many different kinds of chest pains. There's tingly kinds of chest pains. There's a heavy chest pain. There's burning chest pain. There's sharp chest pains. There's knife-like chest pains. There's dull chest pains. There's pressure-like chest pains. It's almost infinite. But that's the quality of the chest pain. What I start with is the consideration of the cause of the chest pain. And there are 5, count them 5, different general sources. Almost, I said almost all chest pains come from one of 5 different causes. Number 1 is cardiac. From chest pains that are coming from the cardiovascular system. That means the heart and its great vessels, like the aorta and stuff like that. Number 2, pulmonary. Chest pains that are coming from the lungs and their linings. Number 3, the muscles and bones of the rib cage. Aha, that's where it sounds like yours fit in, like costochondritis. That's the musculoskeletal cage that protects all the soft organs of the chest, like the lungs and the heart. Pains that are coming directly from there. Number 4, the GI tract. Pains that are coming from the stomach and the esophagus, because you have to remember the esophagus runs through the chest and ends in the stomach, which is below the diaphragm in the first upper part of the stomach. So pains in there in that system can give you chest pain. And then lastly, the last general cause of chest discomfort is here. It's the mind. It's not, and I'm not saying that people are making it up or they're crazy. I'm not saying that. It's stress and anxiety that cause stress pain. So once again, to review, it's the heart and its attached great vessels, the lungs, number 2, number 3, the bones and the muscles, number 4, the GI tract that's adjacent or in the chest, number 5, anxiety. So, Chef AJ, out of all I would sit there night after night because I work 12-hour shifts in the ER, these long shifts, and I would see chest pain every night, different kinds of chest pain. What do you think if you sat there for a year in the emergency room and tallied up all the chest pains? What do you think the number 1 reason is that people end up coming? What was the number 1 cause of chest pain? Because it is emergency room, and you have to remember people have a lot of heart attacks, right? From the food they eat. So what do you think it is?
Well, I'm just going to guess stress and anxiety.
Yes, that's number 1. People would think, oh my God, it's a heart attack. No, it's not. Stress and anxiety is number 1. Give me number 2.
I would imagine a lot of GI stuff because people.
Yes, you're very good.
My God, I'm going to get a job there. But see, this is important, Dr. Weiss, because people need to know when they should go because we don't want to
Exactly. Well, that's what we're going to get to.
Time and resources. And I actually, texted my doctor who was working at the ER. I said, I don't want to wait. She goes, no, you need to go. So I would say, I feel people do have a lot of heart attacks. So I'm going to put that as number 3.
No, I would say probably what you had is number 3.
Wow. Okay. So some kind of musculoskeletal thing. All right.
Yeah. And then 4 maybe that's the heart attacks, and last is the lung problems.
Wow.
So if you think about it, it's a tricky situation because the 3 that are up front, which is the stress, the psychological issues, the GI, like heartburn, like, right? Like, is heartburn going to kill you? No. Is in that moment, is having a panic attack going to kill you? No. It can be, you can think you're going to die, but it's not going to kill you. The heartburn, acid washing up from your stomach into your esophagus, that's not going to kill you. Is inflammation of your rib joints going to kill you? No. But the last two will. And that there's the rub. That's where the problem is because sometimes your doctor has to wade through all the other crap that's not going to kill you to make 100% sure that it's not the fourth and fifth causes. Because if she is wrong, even if like you called me up and you said, this is Dr. Sultana.
Dr. Sultana is my doctor here at True North. Yeah.
Yeah. But even if you called up, oh my God, this is my chest is in, and even if the doctor, it's when I press it, it hurts, they're still going to probably tell you to go to the emergency room to have the tests that give you 100% guarantees or near to it that it's not number 4 and 5, because they don't want to take a 2% chance risk with you, right? So even if they say, you know what, and I've done this before, you know what? Oh my God, I'm 98% sure this is heartburn, or I'm 98% sure, or 99% sure that it's stress or a panic attack or whatever, rib contusion. If you're not 100% sure, you have to be 100% sure. Because if you take 100 patients who have chest pain, which an ER doctor will see no problem in a year, we'll see thousands of people. Or primary care patient, we'll see hundreds of people. And if you're wrong on one of them, that one ends up dead. It could. So that's why, unless the doctor has a strong notion that these are not, that it's very strong, like almost assured that it's not number 4 and 5. A lot of people in our age range, like if you were 25, no. But if once you're 50 years old, 55 years old, whatever, you end up being shuttled to the ER. So,
well, Dr. Weiss, they won't, I don't know what it's like all over the United States, but at least where I live in California, chest pain, shortness of breath, they won't see you in urgent care anymore. Because I had that,
because of what I will.
Okay, because I had a pleural effusion once, and I tried to go to urgent care because it's a lot less stressful. They won't see you for shortness of breath or chest pain in our urgent care. We have to go to ER.
Well, because I think they made that a policy based on procedure, but I understand why, and it's because what I just told you. Because I have to tell you this, unless it's very specific, like if you came to me, I do 3 urgent care shifts a week, right? You come to me and you're in there and I'm looking at you and I'm pressing on your chest wall and you say, ouch, ouch. And I'm pressing on that spot and it's tender. And then I get a chest x-ray on you and I get an EKG. And, I may get like a little blood test to make sure you don't have a blood clot. Maybe that's easy. And if that all satisfies me, I'm not sending you to the ER. But there are many people who have nondescript chest pain and most people do, by the way, when you press on their rib cage, it won't hurt them. They're non-tender. Those are a little bit more mysterious. And because that urgent care doctor or your doctor they can't be 99 or 98%, they have to be 100%. They're sending you to the ER to now get blood tests that prove that you don't have heart attack enzymes, and they can only be run in the emergency room. So basically, if you were 25 years old or 30 years old, I'd probably just do an EKG. It depends on what what you look like. Sometimes the history, and getting the history is so important. Like for the other day, I saw a younger woman, she was 30 years old. And What's the chance that a 30 years old is going to have a heart attack? It's very unlikely. And she told me, the chest pain she gets, it comes when she gets anxious. That's a big thing. And guess what? She goes to the gym every day and runs like 3 miles. And when she's on the treadmill, giving herself a little self-induced stress test, she never gets chest pain. That goes very strongly against, the cardiac issue. So we can weed it out like that. So I'm explaining it to you so that you understand that most of the time it's not a heart attack. I'll give you an example of a kind of chest pain, which is in that 5th category, which is in the lung category, which it can be very sneaky. And that's a pulmonary embolus. And over the years, doctors, especially ER doctors, have become very attuned to ruling that out because it's become more common than we thought. And that can be life-ending. If you have a big enough blood clot that travels to your lung, it can give you, usually it's a pleuritic kind of pain, which means the pain increases when you breathe in. It, like inspiring in, provokes or increases the chest pain. And it's usually more likely in younger people, especially women who are on birth control. That increases the risk factor. We would have to know that. People who've gotten off airplanes or have traveled for a long time, that increases the risk. If you have any history of cancer, like under cancer treatment, most solid tumors, that increases your risk. So that's the way we deal with chest pain. So it seems like you had the chest wall category, and that's it.
But how does the average person know? Because like you say, if you call your primary doctor or any doctor or even the ER, they're always going to say to come because they can't tell over the phone.
I know.
Just
It's so hard. You have to really be a trained doctor to really sort through all these things. There's subtle qualities like we talked about. Number one cause is panic attacks, right? Or anxiety disorder, or stress. That can be all over the place. A lot of the times when the people are having chest pain like that, they also tell you, I'm feeling, because of hyperventilation, I'm feeling something in my hands and my toes, feet too. Like it's spreading to my hands and feet. You can get some radiation of the left side into your hand if you're having a heart attack, but you never get it into the feet. Like if they start telling me that, I'm not going with the cardiac. The GI symptoms, they usually, and the cardiac symptoms, the panic or anxiety symptoms, they're usually directly linked to the event of stress. Like if you're going to a gym and working out and you don't have it then, but every time you get into a fight or you get stressed out, then you have the chest pain with the tingling, then that's more indicative. The GI symptoms are usually described as burning. They're usually associated with lying down. They can be associated with eating and meals, and they're made better by taking antacids or proton pump inhibitors like Prevacid or Prilosec or even Zantac. The third one, which is the musculoskeletal, and that's kind of difficult. They're usually, those symptoms are increased by expanding or moving the chest wall or like picking things up because you're moving your chest wall, right? Pushing things, stretching. That hurts. Heart pain doesn't hurt when you go like this. Lung pain doesn't hurt like when you move, right? Lifting things. So that's the way we usually talk. So basically, for our audience, what I would advise is if you have the chest pain, call your doctor. If you have a primary doctor, tell them. The doctor will weed through all of these considerations on the phone because they've been trained, and maybe they can save you a trip to the emergency room. I find that these days, the urgent cares are so risk adverse that unless you get someone like me who's actually been in an emergency room, who's experienced, a lot of urgent cares are staffed by less experienced providers, like maybe physician's assistants or nurse practitioners. They're more risk averse and likely to send you to the ER.
Yeah. Um, what if you're somebody like me that has, I had GI problems, pancreatitis, I've got anxiety, like you don't know what to do because you don't want
But
to.
in you, it's this. When you press on the rib cage and the person grimaces, it's coming exactly from the ribs. I can't, by pressing like this, I can't get to the heart. I
Right.
can't get to the lungs. I can't get to stress or anxiety, and I can't get to your esophagus.
Yeah, I
It's
didn't know.
only that.
I didn't even think to press on myself, but when he did it, oh boy.
Yeah.
Well, some people are saying, or at least I've read, that it's okay to do this one time, to get everything checked out. So if it happens
Yeah.
again, but some of the viewers are saying never ignore these. Their son died at
Yes.
22 from myocarditis. So we're not telling anyone to not go.
No, that's why I said
Yeah,
if the best thing to do is, if it's not, look, if you're like deer in the headlights, oh my God, I feel terrible, whatever, you call 911. You don't go to urgent care, you don't call your primary doctor. If this is something which is, what, this is bothering me, I think I should call my primary doctor, call them and see if they can help you over the phone.
yeah.
If not, then go to the emergency room.
Why did God put so many things in the same area?
So doctors can have a job.
That's so funny. You're funny, Dr. Weiss. That would be fun to get you as an ER doctor.
Yeah.
That would be super fun.
Do
Oh,
you know, when I was an ER doctor, I started off, how old was I? I was 32 years old. I'm now 63. So it's half a lifetime ago. I'm sorry, 31 years old. And it was in the 90s. And Doogie Howser, the TV show, if anyone remembers that, was very popular. And I remember I had long hair. I looked like a rock star. It was down to my shoulders. And I would come in, and people, at least once a day, can you believe it? The patients would say, I'd say, hi, I'm the doctor, Dr. Weiss. How can I help you? What's wrong with you? And they'd look at me and say, you're not the doctor. They said, you're a medical student or you're a resident. I said, no, I'm the doctor. They wouldn't believe me because I was too young looking. And so then they started calling me Doogie.
that's
Doogie Howser.
hilarious.
Now no one ever makes that mistake anymore, right? No one.
It's so funny that the older you get, the younger the doctors get. I
I
remember as
know.
a little kid, your doctors are always older than you. And then you get to a certain age and they're about the same age as you. And now it's like they're all younger.
Yeah. Well, God willing,
Yep.
right?
Oh boy. Hey, so we've got some good questions from our audience that has
Sure.
submitted them in advance, which we definitely appreciate. So Vi says, hello, Dr. Weiss. There are differing opinions about BMI in the plant-based community. Dr. Furman says a BMI close to 20 is ideal. There is information out there that the elderly over 65, for them, a BMI of 22 to 29 is desirable to avoid sarcopenia and frailty rather than the 18.5 to 24.9 considered healthy according to the BMI charts. Is a BMI under 22 ill-advised for seniors?
Mhm. That's one of the best questions I think that we've ever got on the show. We can talk about this for such a long time. How much time do you want me to devote to this question?
Just enough to
Five
give a
minutes?
thorough answer.
Well, Dr. Furman, in many respects, what can I say? He's Dr. Furman, and he's a mentor to me, and we are almost 100% aligned on everything. And I think Dr. Furman is right. Why do I think Dr. Furman is right? Okay. Well, first of all, is this a live question?
I I mean, it isn't a live question, but I'll check.
If the listener is listening, ask them what is the source of this advice that up to for an older person up to a BMI of 29 is advised.
But 29 is actually quite overweight, isn't it?
Well, it's the last number of being overweight. 30 is obese. 29 BMI is the last number of overweight.
Yeah, Vi, you're here. I see Vi in the chat. Vi, Dr. Weiss is asking where you're getting the information from.
And by the way, it's not that I am questioning Vi's information, because I've seen it. I just can't remember where it's from. I've seen from standard sources, the Department of Health and Human Services, some official source, that actually it's healthier for older adults to be a little bit overweight. To have higher BMIs. So I believe during the COVID epidemic, it was estimated, I remember seeing the figures, that the average American's BMI was 28.5. In the year that I saw the first COVID patient in the state of New Jersey, I remember reading that data, that average BMI American was 28.5. And that alone gave us a 6-fold mortality that year, 6-fold increase in poor outcomes from COVID-19 in 2020, versus if the BMI of the average American would have been less than 24.5. Your Honor, I rest my case. I'm done. There are over 1 million Americans that died in roughly a year, over 1 million, from having poor outcomes, from COVID, from death, the primary one. So we know that's just a reference point where we know when you're hit with a pandemic or a severe viral illness that causes disarray of your humoral immune system, that you are a sitting duck with these inflammatory viruses. And here's a very recent example of where that didn't hold out to be true. Now, let's look at some other data. Across the world, in different populations, which is uniform across in different cultures across the world, we know that body mass indexes of 20 to 22 are the basis for longevity, the longest lived lives. And that's where Dr. Furman, who hits high marks in all of his consideration, goes to 20. Because that's population data over many, many, many years across, it's not just in America, it's across all kinds of different cultures in Africa and Asia and North America and Europe, no matter where you are. So here's another consideration. We have another subset of data which shows us that body fat, so the percentage of what percent of your body is fat and what percent of you is muscle, that it is best for a male to have a total body fat composition of less than 15% of his body is fat. For women, it's less than 25%. And here's what I've noticed almost without ever any exception in every one patient I've ever seen here, because I measure all the body compositions and their body fats. I don't ever remember seeing a patient who was in the ideal body fat category, less than 15% for a male, less than 25% for a female, who did not have a body mass index, a BMI, that was 20 or 21 or maybe 22, not more than 22. So those two different kinds of data sources go together. I'll give you a third one that's separate. There's separate kinds of measurements that are all coalescing into excellence in this band to give you longevity. We know that separately that body mass index is good, that measurement. We know that low body fat percentages are good. How about visceral fat? Visceral fat is a collection of toxic fat that's within the abdominal cavity. And I've seen patients who have normal body mass indexes, but I was surprised to see that their visceral fat accumulations were elevated. But the following is true. Once somebody rids themselves of their, if I do find a person who has, let's say 24. I remember a patient who had a body mass index of 24, but they had like an elevated visceral fat of like a 10 or 11. When they fixed up their diet, everything lined up like targets in a row. Their body mass index became 20, like Dr. Furman says. Their body fat composition became not 14 or 13. It was a male, less than 15. It became 9. It became, or 8. It became like an endurance athlete level. And their visceral fat became 3. It dropped from 11 to 3. It was phenomenal. So I look at all these things. And by the way, there are other then further out connections of blood pressure excellence, of insulin resistance excellence that are dependent on these core 3 measurements of body composition, which is body mass index, BMI, the total body fat and muscle composition, and visceral fat levels. Those 3 things. They're like the trefoil of intersecting excellence. And that's why we always take them into consideration here in our practice. It's unusual that we would get a person who has an elevated BMI like 25 or 26, where they wouldn't have problems in this area. Their blood pressure is not so good. Their cholesterol is not so good. Their insulin resistance is not so good. They're pre-diabetic. They have metabolic syndrome to some degree. So I agree very strongly with Dr. Furman. Let me just spend one more minute explaining for our audience members who don't quite know what body mass index is and why there's a little controversy about it. You ready? Okay. What is body mass index? Oh, it's the most common way that doctors and insurance companies, life insurance companies, we can tell whether you're underweight, normal weight, overweight, obese, extremely obese. It's a chart. And basically you put your height on one axis and your weight on the x-axis. So I think it's the height that's on the y-axis, the vertical axis, and weight is on the x-axis or horizontal axis. And what you do is you go on the chart, you find out what your weight is on the horizontal axis, then you go on the vertical axis, find out what my height is, and then you draw a line out, and where they meet, that's the point on the chart where you are. And it's usually a color-coded chart. And the zone, wherever you're meeting, it's either a zone of normal weight, underweight, overweight, very overweight, obese, and very, very overweight. And they color code the chart so it's visually easy to see. So the body mass indexes are specific number. It's not your weight. They're specific numbers applied to the little boxes within each zone. We know that the normal weights, all of them, no matter how tall or short you are, that the body mass index weights, and this is why we can compare a 5-foot person to a 7-foot person. Because obviously a 7-foot tall person is going to be way much different than a 5-foot tall person, right? Optimally. So, if a 7-foot tall person whose optimal weight can still have a body mass index of 20, just like a 5-foot tall person optimal weight can have 20. So no matter how tall you are, if you're optimized, you get the same BMI number. Now, why do some people think this is controversy and it doesn't work out? Well, there are some people where this doesn't exactly hold true. Everything I've said, where a body mass index of 20 may not be optimal for them. And in general, that holds true for very muscular individuals. These are bodybuilders who have great muscle mass, who work out all the time, and you don't have to take steroids, but if you've worked on hypertrophying your muscles by doing resistance training every single day, so you're in a fitness competition body, those people can be because muscle is heavy and they have a lot of it, and those people don't tend to have any fat. They can relatively be too heavy for their height. Their heaviness is not coming from fat accumulations because they're in great shape. Their heaviness is coming from hypertrophied muscle. And so if you take a look at Arnold Schwarzenegger during his prime, right? You know what he looked like, right? And you put his height and his weight, I think he was like 6'2". He was obese, probably. He got an obese neighborhood BMI because he had such massive muscles. But so the scale doesn't apply to someone like that. But to most of us mortals, it does apply and it's okay. So
By who is watching live said, are the home scales that measure body fat reliable or accurate?
I think, there's all different kinds of home scales. The one I like that I have found very reliable over many years is called Omron. OMRON. I like that one. I find it's highly consistent. It's consistent with my other scales. I trust it. Let me see if it has a name. The Omron Omron. I don't know if you'll see it. It's an Omron. It measures visceral fat. Here, I'll show it up so the audience can see. I can't remember if this is an old one or new one. You stand on it. It gives you all that. It gives you your digital weight, how much you weigh. It gives you your body composition. It will give you your visceral fat. And it also calculates this spooky kind of thing called the body age. And I don't know, that's proprietary. I don't know how they do that, but it's spooky because I think it's usually right. I find that the plant-based whole food people are usually years younger than their actual chronological age you put in here. And when people are sick and overweight, they're years older. So that's the BMI.
Yeah. Well,
I'm sure there are probably people who have a lot of questions on that.
Absolutely. Like
Nancy, it's a very controversial. You'll see people who, that's bullshit. It doesn't. I find it reliable. Look, I have had people who are not like Arnold Schwarzenegger, but they're really, I'm looking at them. They don't have a lot of fat, but they're big. They're strong people. You know what I mean, right? AJ, you've seen these people, like they're muscular. They may not be in weightlifting competition, but you look at their biceps and they're big, but they don't have a gut here or whatever. I allow them to be, so they shouldn't be 20. Maybe they should be 22, okay, 23, but they shouldn't be 26 or 7. Let me say one last word about the elderly. I do not believe, I don't buy that it's okay for elderly people to have higher BMIs. And the reason why is because as we get older in the elderly, what happens, AJ? Our muscles shrink, right? we get sarcopenia because we lose estrogen, we lose testosterone, we lose our ability to build muscle, to assimilate, to absorb protein. All these things are going down. So that means if your body mass index is going up and you're elderly, it's from fat. And there's no, I don't care what people say, there's just no reason to have extra visceral fat. Extra visceral fat causes disease, period. Causes increased cholesterol, elevated blood pressure, increased insulin resistance. Who wants those things?
Nobody.
No one.
So Nancy, who's watching live, said, "What about the DEXA scans that are used to measure bone density, the same to measure visceral fat? Are those accurate?"
That's a whole nother topic. The DEXA scan measures, whereas these things don't use radiation, they're just weighing you basically and have computer chips that are calculating. These things that I'm using, the Omron, passes a very weak electrical impulse. You can't even feel it. The DEXA scan actually uses very low radiation, like even less than a dental x-ray. That's why you don't have to put on a lead apron. And it's a different kind of test. Suffice it to say that I do order DEXA scan tests to get an understanding of where someone's bone mineral density is, because I think it is useful. But just be aware that the testing and the guidelines and everything set up that's aligned with it is probably aligned with the drug companies, and why you should be doing this test is because if you have osteoporosis, you should start taking drugs. Where I don't do it because of that reason. I do it so that I can get a baseline for a patient, and if I see that their bone mineralization is poor, I can use lifestyle like load-bearing exercise, making sure they're eating enough whole plant proteins, making sure their vitamin D is okay, making sure they're moving, stuff like that. And so I use it as a baseline to encourage healthy behaviors so I can show the patient, hey, look what a good job you did. You've been jumping rope for a year, you've been lifting, weights, you've been doing push-ups, you've been doing all these things. And look, you actually improved your bone density score by doing this. And so then that encourages continued good behaviors, right? If you knew that, if I told you had osteoporosis or whatever, you don't know what you have, it's a shot in the dark, right? I don't know what I'm doing. If I say, I got you this bone density test and your bones are not good, AJ, and then you're doing this 365 days and you're eating the 70 grams of protein, you're getting this much calcium, and then I repeat it and I said, oh my God, you improved it by half a point. You'd say, now I know what to do, and I'm going to keep doing it. That's why I think the DEXA scans are useful. It's if you're going to do something that's healthy about it. I don't necessarily think that taking the bone drugs, if you just have primary osteoporosis, is the best thing to do.
Got it. Thank you. Okay, here's a question from Maria. I am turning 60 today on Friday the 22nd. Happy birthday.
Happy birthday, Maria.
Now she can count the years to Medicare. 5 more.
Yeah.
Okay. I've been whole food plant-based for the last 6 years. In the last few months, I have been getting varicose veins in my leg. My mother has them, and I was wondering if it is normal as we age. Is it serious? Is there anything I can do about it?
Yeah. So, alas, of the many, 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 many things that I think whole food plant-based can reverse, I've never noticed that varicosities or blown out veins is one of them. Never noticed it. And that includes varicosities of the anus, in other words, known as hemorrhoids. Like once you have them, You can fix up your diet. You can fix up, as long as you're not constipated, you have good bowel movement. Sometimes the hemorrhoids will just persist. The same thing, basically, the varicose veins, hemorrhoids are like varicose veins of the anus. They're enlarged, stretched out veins that are pooling with blood. And that's what you have in your legs. And, once they're stretched out like that, the problem is that veins tend to have natural one-way valves in them that gate or stop blood flow from going backwards. And varicose veins, when they're all stretched out, those valves are shot. And it's a mechanical problem. There's no real way to get those valves back, no matter how good you eat. I've not noticed it ever to be done. So and by the way, I will put this in, and then that there is that vascular specialists think, and I think that there may be some familial tendency towards this. I think that to increase your risk for getting this. So if your mother had it, maybe that's why that plays a role. I noticed that when I was we talked about my ER days. I noticed I don't have varicose veins, but I have spider veins in my legs. And I noticed that after standing for 7 years for 12 hours straight in the emergency room, that's when these things popped out, these spider veins in me. I didn't have them before. So I think that standing for long periods of time with allowing the pressure of the blood to pool in your extremities makes you at risk for it. I think possibly your genetic profile makes you at risk for it. What can you do then to help yourself? Put up your legs, get compression stockings, venous compression stockings. Those are the non-aggressive things. And the more aggressive things, which can be very helpful, are surgical options. It's if the veins are smaller, they can inject them with sclerosing agents, which make them shrink down. If the veins are larger, they cut them out. They strip them out of your leg. Sometimes varicose veins are not only unsightly, but they can actually cause a lot of pain. And if they're just unsightly, well, then it's an aesthetic thing for you. If you don't care about it, you'll have varicose veins. Like my little veins, I don't care about them. They don't hurt me. I just don't care. But if your varicose veins don't bother you and you don't care, mind the way they look, then you won't have anything to do with them. If they're either painful or if you're mortified by the aesthetics of them, you should get them treated surgically by a vascular surgeon. Yeah.
Thank you. Okay. So it's not everybody gets them as they age then. It's
No. There are people with perfect legs. It's not,
okay.
I think, it's not necessarily a factor of age. But age doesn't help. Those who are at risk for getting them, age doesn't help you. Maybe give me one more, AJ, because I see that I have a patient I have to get to.
Okay. Well, let's see if we can get through one more. Okay. This is from Christy. It's about Hashimoto's and kelp. It was suggested in a video I saw that if you aren't using salt and have Hashimoto's, you should take a kelp supplement for iodine. I have been, but I'm wondering if you concur with that opinion. I had my doctor do the anti-TPO antibodies test to test my blood work in October to see if I've put my Hashimoto's in remissions like I did with the psoriatic arthritis. If my levels are normal, should I continue with the kelp? P.S. The endo who diagnosed the Hashimoto's told me it's no big deal.
Well, it doesn't necessarily, first of all, we don't know what this lady's iodine level is, do we? The iodine is most accurately measured in the urine, not in the blood. You can get a blood level, but it's not supposed to be that accurate. So I get urine spot iodine levels. I get that once a year on every patient just to make sure they're okay. Whole food plant-based eaters, I would say about a third of my patients, maybe 20% of them, undetectable iodine levels. And I have had a patient who had one or two of them whose thyroid was slow. They were undetectable in iodine. And when I gave it back to them, they didn't need levothyroxine anymore. They didn't need Synthroid. So I think it can work. I think it's worthwhile to make sure your iodine levels worth good, to make sure that's not causing any thyroid problems. I don't know. I'm not saying, I don't, if anything, I think a thyroid, an iodine deficiency, the problems it probably would cause with the thyroid are inactivity of the thyroid, or possibly we think maybe even thyroid nodules, which can be problematic, but I'm not sure there's an association between low iodine levels and Hashimoto's. Hashimoto's is an autoimmune disease. So with this lady, I would check your urine iodine, ask your doctor to check that if it's, and or not check it. And I would just empirically, you can just start eating seaweed. Eat 2 sheets of nori a day, eat a teaspoon of dulse flakes, D-U-L-S-E, or a teaspoon of arame, A-R-A-M-E. They're little, you can sprinkle it on your oatmeal or eat it, sprinkle it on a soup or something. Just eat it every day. There are other benefits to eating these seaweeds, like very good benefits, anti-aging benefits, potentially, anti-breast cancer agents benefits. And I would just do that. And that's it. I wouldn't worry about the one thing I tend to tell patients not to eat is kelp. And it's because kelp is so high in iodine that it can be crazy. Like I've seen people eat some kelp stuff and their iodine level shot off the chart. So if you want to get, so I think I tend to tell people to just eat the natural seaweed and not have it be kelp.
Okay. Well,
Okay.
Thank you, Dr. Weiss.
Okay, AJ.
So we'll see you next month, okay?
It'll be my pleasure.
All
Thank you
right.
for always having me.
Thank you. Oh, it's our pleasure. And if you didn't get your question answered this time, send it to help@chefaj.com. If you're in the membership community, it goes up in the queue. And come back Monday a little earlier at 9 a.m. for Dr. Brooke Goldner of Goodbye Lupus. We're going to talk about the magic of cruciferous vegetables. And I know Dr. Royce loves cruciferous vegetables.
Yeah, it's our specialty here on the farm.
Thank you so much.